Hello, my friends. I am Yervand Hakobyan, a hematologist from Armenia, and now I'm happy to share information what is the remission for ALL patients. The remission means that signs and symptoms of acute lymphoblastic leukemia have decreased or disappeared. It doesn't always mean that cancer is cured, but it is a significant positive response to treatment. For acute lymphoblastic leukemia, remission is a critical milestone. I can say that for doctor, it's really a very fantastic goal, but reaching the remission is not mean that we finished our work. Even contrast, started new chapter in our battle, doctor-patient battle against the cancer. When we are reaching remission, we should understand what means the remission and what kind of remission we have. We have two main types of remission. I am saying the main types because we have another subtypes as well. The main types of remission, the complete remission and partial remission. What is the complete remission? Complete remission indicated that all detectable signs and symptoms of ALL have disappeared, including the absence of leukemia cells in the bone marrow as determined by the standard test. This means that blood counts, bone marrow biopsy, when we finding less than 5% of blood cells in marrow, and other tests show no evidence of leukemia. We have a normal level of white blood cells, red blood cells, and platelets. Also, no signs or symptom of disease. While complete remission is a positive sign, it does not necessarily mean that cancer is completely gone. Very small numbers of leukemia cells may still be present at undetectable levels, which is referring to as measurable residual disease, and we calling it minimal residual disease positive remission. Still, incomplete remission by standard criteria, but very small number of leukemia cells remain detectable only by advanced testing. This indicated a high risk of relapse. If MRD is undetectable, this is considering as MRD-negative, and we're calling it minimal residual disease negative remission. No detectable leukemia cells using highly sensitive molecular tests, for example, flow cytometry or PCR, and it's indicating the deep remission and low risk of relapse. For some, being in complete remission for a certain period, for example, 5 years, may lead to the term cured being used, but even then, a recurrence is still possible. We have also another type of remission, one of them, complete remission with incomplete blood count recovery. When we have less than 5% blood cells in bone marrow, but blood count are still abnormal, often cured during recovery from chemotherapy. Also, we have a partial remission, indicated that cancer has responded to treatment, but not completely. This means that the number of leukemia cells in the bone marrow has significantly decreased, or the tumor size has shrunk, but some cancer cells or signs of the disease remain. Partial remission is often considered a chronic condition that require ongoing monitoring. A 50% or greater reduction of tumor size is often used as threshold for defining partial remission, although it can be varying. Important consideration: remission doesn't not always mean the cancer will not return. In ALL, even after achieving a complete remission, doctors often continue monitoring for MRD to assess the risk of relapse. The approach to treatment during remission depends on the specific type of ALL, in the characteristics and the patient overall health. What after the remission? In acute lymphoblastic leukemia, remission is primarily measured through the absence of detectable leukemia cells in bone marrow, assessed via microscopy and molecular techniques. Additionally, the duration of remission is a critical factor. With sustained remission, maintaining remission for a specific period like 6 months, being a more robust indicator of treatment success. Now, more details about measuring of remission. First, microscopic examination of bone marrow, morphological remission. This involves examination of bone marrow samples under the microscope. Complete remission is typically defined as having less than 5% of lymphoblasts in the bone marrow. Limitation of this method, while microscope examination is a standard, it can miss low level of residual leukemia cells, which might not be visible under the microscope, but still present. Second, molecular monitoring, quantitative PCR, more sensitive method, like it's calling the polymerase chain reaction, can detect minimal residual disease at level much lower than what's visible microscopically, allow for the detection of even a few leukemia cells among the myelin or of normal cells. Other molecular techniques, like flow cytometry, can also be used to assess MRD. Duration of remission is very, very important. Sustained remission, simply achieved remission, isn't always the end of goal. The duration of remission is also a critical factor. Sustained remission, maintaining remission for a set period, is a more reliable indicator of long-term success. Example, in some cases, remission is defined as maintaining a state of less than 5% of blasts in the bone marrow for at least 6 months, according to studies published in scientific journals. Other factors, clinical assessment, overall health, including physical examination, blood count, and assessment of any other symptom is also considered. To summarize how remission is measuring, first, bone marrow biopsy, most critical test, look at percentage of leukemia cells in bone marrow. Second, minimal residual disease testing uses sensitive techniques like flow cytometry or PCR to detect small number of remaining leukemia cells. And MRD-negative status is a key goal associated with better long-term outcomes. Blast test, check for normalized white blood cells, red blood cells, platelets. 4, physical examination and symptoms check, absence of symptoms of like fatigue, fever, infection, bleeding is also a measurement method for remission. What after the remission? Next step after the remission. The first step is consolidation therapy with high-dose chemo or target therapy to kill any remaining leukemia cells. Second, maintenance therapy, long-term, low-intensity treatment, often oral chemo, to prevent relapse, especially in children and young adults. Also option the stem cell transplantation if needed for high-risk patients or those with MRD after initial treatment. Often recommended if relapse risk is higher or if remission is hard to maintain. Ongoing MRD monitoring, regular bone marrow and blood tests to catch any early signs of relapse. To summarize, what happens after remission? First, consolidation therapy, high-dose chemotherapy to eliminate any remaining leukemia cells, usually starts soon after remission if achieved. Second, maintenance therapy, low-dose chemo over months, 2 years, commonly 2-3 years, helps prevent relapse. Third, MRD monitoring, regular testing for signs of leukemia returning. 4, stem cell transplant for high-risk patient may be recommended if MRD positive or other high-risk features are present, often potential for long-term cure. And 5th, regular follow-up, ongoing blood tests, physical examination, and possibly MRD tests. After achieving remission from acute lymphoblastic leukemia, the focus shifts to long-term follow-up care, managing potential long-term effects of treatment and supporting emotional well-being for both patient and caregivers. This includes regular checkups, managing side effects, addressing emotional challenge, and adjusting to a new normal. For patient follow-up care, regular checkups with the oncologist or primary care physician are critical to monitor for recurrence and address any late effects of treatment. These checkups may include blood tests, bone marrow biopsy, and imaging scan. Life effects management. Be aware of potential late effects of ALL treatment, such as heart problems, lung issues, or endocrine problems, and discuss them with your doctor. Physical health. Maintain a healthy lifestyle with regular exercise, balanced diet, and adequate sleep. Emotional well-being. Address any emotional challenge, such as anxiety or fear of recurrence, by taking to your healthcare team, joining support groups, or seeking therapy. Quality of life. Focus on activities and hobbies that bring joy and meaning to life. Self-advocacy. Actively participate in your follow-up care, plan and communicate any concern or needs to your healthcare team. Also very important, the role of caregivers. For caregivers, support the patient, continuing to provide emotional support and practical assistance, but also encourage the patient independence and self-advocacy. Caregiver support. Seek support for yourself, as caregivers can be emotionally and physically demanding. Maintain boundaries. Establish health boundaries and prioritize your own well-being. Communicate with the healthcare team. Stay informed about the patient progress and any concerns, and communicate openly with the healthcare team. Prepare for the future. Help the patient plan for the future, including financial planning and managing potential long-term effects. Acknowledge change. Recognize that life may be different after treatment and adapt to the new normal. Specific consideration for ALL, MRD. In ALL, MRD monitoring is critical to assess remission status and risk of relapse. Consideration and maintenance therapy. Some patients after remission can feel that they reached the main goal and can refuse the treatment. Here is a very, very important part of treatment to explain the patient that continuation of treatment, that means the consolidation therapy or maintenance therapy, which can have a duration 2-3 years, is very important. They have a similar importance than even induction therapy, than reaching remission. That's why here is very important to work with patient and explain, to have understanding that this part have the same importance for patient and result of treatment. And summarizing some tips for patient and caregivers. For patients, stick to treatment schedule. Follow medication and clinical visit carefully. Stay informed, understand your treatment plan, and ask questions. Track symptoms, report new symptoms, side effects, or fatigue, infection, bone pain. Maintain nutrition and exercise. Eat balanced meals and stay hydrated. Support recovery and immune function. Mental health matters. Seek support for anxiety, depression, or stress. For caregivers, being an advocate. Attend the appointment. Ask questions. Help manage meds. Stay organized. Keep the binder or digital folder of test results, appointments, and contact info. Provide emotional support. Offer empathy, not just logistics. Be a listener and a calming presence. Communicate with the care team. Ask questions and advocate for the patient. Take care of yourself too. Watch for burnout. Take breaks and ask for help when needed. Stay connected. Join support groups for caregivers of cancer patients. Understanding ALL helps you support the patient better. Thank you.